Hi there. My name's Alan, and if you're watching this video right now, most likely I'm going to be a resident and you're going to be in my group of interns. So I just wanted to give you guys some of my tips on video so I wouldn't have to repeat it a bunch of times. Alright, so first off, organization. I'm going to talk to you about how to do my SCUT sheet, which Dr. Freed taught me, and I also came up with some parts myself. So the first thing is you'll get a list that's printed out that'll have the patient's names on it. Like for example, my last name is Trong, and then it could be Smith. It could be anything like Barnacle. All right, so these are your 3 patients for the day, right? They'll be divided like this already for you. The thing I like to do is this column-based thing. So I might like to make several columns. Okay, like one column like this, one column like this. It's all a little hard to see on this lined paper. One column like this. Okay, and I like to actually divide this one into 2. Okay, so what do these mean? So this one is my subjective column slash overnight events. Okay, in this column, basically when you get sign out in the morning, you can put overnight events like, okay, no acute events overnight, or this one had like a fever, got blood cultures done, and a whole workup. This one, whatever, also nothing happened. Okay, and then when you see the patient in the morning, what I like to do with this part is, you look at your vitals, write anything relevant that stands out, like, whoa, they had a 104 overnight, or they're tachy, to 130 or something. All right, and then when you see the patient, you ask them like how they're doing, any review of systems, any cough, nausea, fever, stuff like that, and you examine them, right? So anything that's like, you don't have to do this, but this is what I used to do. Okay, no complaints. Okay, this one like felt like vomited twice or something. Okay, and then the exam, like, oh, I heard crackles at the bases on this one, and this one had like new lower extremity swelling, something like that. So that's kind of that column. Okay, the second column is to do. Okay, to do meaning like things that you already thought of doing from the day before. It's like, oh, I need to I don't know, well, okay, actually, to do, one of the things I do is these few things. Let's see, what did I call it? N, P, L, D. I actually wrote this for every patient. You might get your own system, but I'll explain this. What does this mean? Each of these is a checkbox, okay? You don't have to make the box every time, but like note, your progress note for the day, which should be done by noon, they want. Okay, P for provider handoff. So provider handoff, that's that thing on the top right corner that you write the to-do, like what has been done every day, like everything we did for the patient. We adjusted this medication, added that medication, adjusted the heparin drip, whatever, called so-and-so. So you have to do that by 4 p.m. every day. Okay, this I'll just write by noon. This should be done by 4 because we sign out at 5 and you want to get ready to sign out. L, morning labs. Okay, this make sure to order morning labs before you leave for the day. And then D is for discharge. This one I kind of like circle if my resident, if I'm going to be telling you, oh, we're going to discharge the patient today or tomorrow, you should keep an eye out for this one, checkbox. Okay, other things are like if I ask you to order something and be like, oh, okay, I got to order PTT at some point if I didn't do it, or like random stuff like, talk to family. Okay, so these 2 columns are pretty crucial. The first one is the most crucial. It's to call. Okay, this column to call. This is crucial because calling consultants, like calling consults or calling primary doctors outside, calling everyone is very important to do earlier in the day because no one wants to be called late in the day. So I'll mostly be taking care of this in the beginning of the year, but you guys should be familiar with this. So like cardiology consult, right? Or like endocrine consult. Or like call pharmacy to get a med rec. right? Or call family to get collateral, stuff like that. So the reason that we have these columns is that when you look at all your columns and you're so confused of what to do, the best thing to do is actually look at the call columns first. And well, if it's later in the year and we let you guys call people, then you would call those first, okay? This other column is to check things to follow up on, meaning like if you ordered a 2 p.m. PTT for your heparin drip, to adjust the heparin drip, you write 2 p.m. PTT to watch out for. This one might have like echocardiogram, okay? And then they have like CT chest. So they're in for these tests. They might go at some point, or you're waiting for the result, whatever. Like I just put these here. Also electrolytes, keeping potassium above 4, magnesium above 2, and then phosphorus above 2.5 if you're checking phosphorus. You usually don't check phosphorus unless they are in respiratory distress and they're using up ATP, or they might be like really like an alcoholic or a starvation person and they might get refeeding syndrome, then you check phosphorus. But usually, this is usually potassium and mag with a cutoff of 4 and 2, okay? And then once I got the echo result, let's say your echo result came back, and then this is what I do. This section I put for notes. Anything that didn't fit in over here, echo, it's like, you don't have to write everything because that'll be like too long, right? Just write the main things here, but write the rest in the provider handoff. But like, oh, the EF is 45, there's some wall motion abnormalities, and there's like a small pericardial effusion or something, okay? And then if you repleted your electrolytes, I usually just check it off. And once you call these endocrine consult, you say, oh, call, then I usually say follow up, like their recommendations, look for the note later, follow up with them later. So that's kind of this thing. And the other thing for notes is anything that you've done for the patient during the day that wasn't already covered over here, like a check mark. Like let's say someone's like, oh, like let's say I, as the resident, tell you, I added this medication, we started metoprolol on this patient. So you just to keep that in mind for your provider handoff later, you don't have to write like, hey, order metoprolol, because it's already been ordered. So you'd be like, okay, we added metoprolol for this patient. And then you'd put anything for the day, you'll put in the provider handoff before you leave. Okay, the next thing I wanted to cover is pen colors. A lot of people have different systems. I'm going to tell you the system I recommend for you as interns. Okay, first off, black. Black is your main color for the morning when you're making your thing, when you're putting your own to-dos, like get your own plan for the patient, the subjective stuff, everything in the morning before you talk to me, your senior. Blue, so I like to do resident rounds around 8:15 or so. So after you've seen all your patients, you can, and then you talk to me, present to me as if I'm the attending. Anything we talk about, then you could use blue to be like, oh, Alan said to, actually like, I don't know, talk to, I know we already put talk to family, but like, let's say I said this, okay, then you write it here, or like say, hey, can you order another like set of labs for like 4 p.m. or something random that you didn't come up with first. You can put in blue so you'll know like later, oh yeah, we talked about with the resident. Okay, the next one is when we have attending rounds at 9:30. Whenever your attending comes, we're on attending rounds. Whenever the attending asks you to do something, you better remember to do it, because they'll always check up and they'll actually evaluate your performance based on how well you follow up on tasks. That's why I write this in red, like, oh, Dr. Meng said to look up the dose of Eliquis for this patient. There's a few different criteria for that, and get back to her later. Or like, oh, make sure to discharge by noon. So it's like very soon, it's like, oh man, so red. My last color is green. All right, green is kind of a special color. It's really for me, it's for stuff like towards the end of the day at 4 or 5, someone says, hey, put this in for the night, sign this out to the night team, make sure that they do a trial avoid, after we remove the Foley. at midnight or something. Or for the next day, I use green for the next day too. It's like if someone asks you, hey, remember to call that person tomorrow. We don't have to call them today, but call GI tomorrow or something. So you'd be like, okay, in green, GI consult in AM. So that's how I use green. Alright, the other way that I use blue, and this is for the residents only, is we have something called interdisciplinary rounds after attending rounds, where we talk to the case managers, social workers and stuff, and they'll be like, oh, order PT for something, or get a PPD on someone. So that's, for me, I use blue for that, but don't worry about that. For you guys, I recommend using blue for like resident rounds. Alright, so the other thing that I recommend, you guys may not need to use this because you only have a few patients each, but as a resident, or like when you try to get ready to be a resident, this is one method I like to use. Basically, there's two main sheets of paper I carry around. One is this scut sheet of like what to do for the day. The other is a sheet of like the patient's names, and it's basically a mini sign out. You'll put their name on this side, their room number, their age, which attending is on there, and then over here I like to put the past medical history up here. You can't remember everyone's past medical history offhand, so it's good to write it down here. And then I like to write a little bit about how they were, what made them admitted. I'd also put like the day they were admitted here, and then like recent stuff. And the thing that's cool about this is you keep it day to day, and then anything that new that happens on your patient, you could write some stuff here, but like for example something like an echo result or CT chest result, something you want to know long term, I actually tend to write here. Like even though I've written this day before or something, I'll write, okay, their echo showed this, their CT showed this, their Dopplers showed this, oh, they developed fever this day, stuff like that. So that way it's easier to remember kind of their whole hospital course. Some people like to type this part up. I like to do it in real time by writing it down. And then if you discharge the patient or transfer them, you can just cross it out. And then if you have an old sheet that has 4 crossed out, you could throw it away. That's my method on that. So expectations on how the day should run. So I expect everyone in the beginning of the year to come in by 5:30. I know it's very early, but I'm going to try to come in around like 6 as well. This will give you adequate time to really see your patients, look through their vitals, look through their labs, look through all their orders, what medications are there, make sure that nothing's missing, like DVT prophylaxis, like why are they not on Hep sub Q, there might be a reason. If not, then like make a note to talk about it with me during resident rounds. And then when you see the patients in order of how sick they are. Basically, whoever you remember is like the sickest, go see them first. The next priority is to see new patients that you inherit in the morning. But let's say you're still here at like 5:30 or 6, you're not going to have new patients, obviously. So really in order of like who's sick, who's new, and then the old ones. Okay. The ones who are stable, awaiting rehab, see last. The thing is, if you know someone's like not that sick, they're like stable and stuff from the days before, but when you look through their vitals, something's really wrong. Definitely go see them sooner. The other thing that I will show you in person, when you're on your EM, actually I'll show you. Alright, so instead of showing you on the computer, because there could be HIPAA related information, I'll show you here. So think of this as an example of your electronic medical record. Okay, you'll just have your list of names, Trong, Smith, Barnacle, or whatever. Okay, so you'll have your computer list. It'll also kind of be like this. Alright, you're gonna start out with an EMR that's this whole bunch of like disorganized columns that you don't need, like new alerts, new documents, like unacknowledged. There's so many things, so I'll show you how to redo it to be more organized. But some of the main columns you're going to want to see, obviously you'll want their name, hospitalist assignment. You'll know if the patient is under the service hospitalist, meaning like Dr. Ilias, Dr. Meng, Dr. Cambo, Dr. Wong, people like that. You'll know who's going to be taking the patient for the day. They will put their initials. So Angel Meng will be AM, NI is Nazish Ilias, JW is J Wong, VO is Vladimir Ornstein from overnight. There's JM, Joel Matthew from overnight. There's Hannah Fraley, HF. There will be AS for Anand Shukla. Those are the ones I can remember right now. Oh yeah, GL for Gabriel Lesung. So these are some of the hospitalists. These ones are at night, so I'll cross them out. Not that they're less important, but those are some of the names, so you'll know. Sometimes they'll have nothing. It might be a private attending, like one of the other attendees. Okay. Resident assignment, this will be important for you to change. And I'll help you change it. Meaning, what is resident assignment? It is basically your last name and pager number and my last name and pager number. Basically, you'll always see intern, name, and then 917, 219, whatever. And then R will be resident, Trong is me, 917, 219, blah, blah, blah. Okay, so when you inherit a patient from overnight, it'll have something like this, night float something. Okay, you're gonna need to change that to your name and my name. That way, anyone looking at it, the nurses, the hospitalists, me, like other residents will know who's taking care of the patient. This is the part I was kind of alluding to earlier. You want to always, how do you be aware of whenever you have a new result right away? Like when your echo result comes back, you'll know right away. When, let's say I order something and I didn't talk to you about it, you will know right away and you'll be like, hey Alan, why did you order this? And then we'll talk about it. So the thing is, this flag new, every patient starts off blank. So you'll want to, any new patient you get, you'll need to go to this column, double click, double click, double click until you see this symbol. That way, this one it'll show up with these like red or yellow markers, and this will mean there's a new, like red is like immediate result of some kind. Yellow is maybe it's not, it's like an EKG or like a blood culture result. So you'll want to double click DC, double click each one. You'll see the result and you'll be able to say clear flag. Okay, and the goal is you always want all your flags cleared at any given time. So if you're ever on your computer, you see a new flag pop up, you should double click it, see what it says, take note of it, of course, on your notes or this one, and then clear it. That way you always know what's going on. One time this is important is in the morning. You show up at 5:30. What's the first thing to do? You look at their vital signs. I already talked to you about this. You look at their labs for the day, but usually this hasn't been done yet. They'll be done a little later, so check up on it later. Okay, you look at their orders. Just get a sense of what medications they're on in general. Try to categorize them by what they're for. Like they're on these medications for heart failure, they're on these medications for coronary artery disease, they're on this antibiotics for pneumonia. That way it's a little easier to remember. And then the other thing is always clear the flags. Because at 7 o'clock, you're going to get sign out. Okay? And someone might say, hey, this patient, nothing happened overnight, right? But when you go back and you look at Trong, you'll be like, wait, they were ordered for Tylenol, they were ordered for blood cultures, and then in your vitals you see a fever. So you'll know, okay, the person telling you that sign out, they didn't, they missed something. Or you might see, oh, they were ordered for Duanebs ×2, and they were ordered for BiPAP, and they said, the person overnight said nothing happened. You'll know something happened before you go to this person. So if that person tells you, hey, nothing happened, you'll be like, okay, but then why were they ordered for Duanebs twice? Why were they ordered for BiPAP? Did something happen? And they'll be like, oh, yeah. Sorry about that. This happened, and then we had to escalate stuff. But they're okay. They're on the floor. Okay. Make sure to always clear these flags. I think this is one of the last things I want to cover, the schedule for the day and my expectations. Alright. So I'm a pretty chill resident, but we'll try to have a structure today. So like we said, 5:30 a.m. Arrive to hospital, spend 5-10 minutes getting settled in, and then 7 a.m. this is when you go to 6 Black Hall for sign out. Okay, And what do you do between here is you see patients like we talked about before. If anyone's sick, alert resident if sick, or if you're not sure, even if it's a little bit, just let me know. If I'm not there yet, just text me. If something's really, really wrong, just call a rapid response, or it's better to err on the side of caution. Like if you're really unsure, if you can't reach me or anyone else or the nurse, the night team will still be there. So at 7 a.m., this is when we get sign out on new night float patients. This could be anywhere from like 0 to even 8. 8 is unusual, which we'll distribute among the interns. And then I have to see everyone, okay? 8:15 is when we would like to shoot for resident rounds, meaning you'll round with me, pretend I'm the attending, present the patients to me like in a systematic order from overnight events, how subjective, how they felt this morning, what their exam was, what their vitals were, vitals and then exam, I'm sorry. We go through labs and orders together. We can go over the plan together. Not as formally as with the attending, but try to be as thorough as possible. If it's a new patient, we'll try to be more thorough. Okay. If we have several interns, we may stagger this, 8:15, 8:30, 8:45 perhaps. Then 9:30, this is when our attending will show up. Okay. And, this one will formally go over the plans with the attending. This lasts until 10:30. Okay, what happens at 10:30? 10:30 is actually when resident, which is me, goes to interdisciplinary rounds, like with the case managers, social workers, and everything to see, like, give them updates on how the patients are doing, when are they ready to leave the hospital, will they go home or will they go to rehab. During this time, this is a time for you guys to get started on your, so you guys, you can started on your progress notes. You can put in any orders we talked about on rounds. Orders come first. Okay. If there's any phone calls to make, I'll probably make them later, but if it's an important phone call, you can do calls as well. Do these first, and then do notes afterwards, but notes are important to get done by between noon and 2. They want it by noon, but so orders, calls, do anything, and then if you're unsure about something, you could always text me, even though I'm on IDRs. At around 11, this is when I come back from IDRs. This is when I will tell you who is getting discharged and when. So I will give you guys an update on who's getting discharged. That way you can prioritize the discharges. Ideally, you should write the discharges, hospital course and all the discharge instructions a day in advance or more if you already knew they were getting discharged. But yeah, who's getting discharged. Then we have this whole period of time until 12:30, okay, to get all our work done. We'll run the list together, we'll call people, we'll order stuff, you'll write your notes, and then we'll discharge some people maybe. And then 12:30, this is usually when we have noon lecture. This lasts until 1:30. So the way it works is at 12:15 or so is when we really should be gearing up to go get lunch, because they don't want people to be late for 12:30, and this is in Bruno Hall. This is on the first floor. It's a little hard to get to. We'll talk about it. Okay, so get lunch 12:15, 12:20. We come back at 1:30. Then we have from 1:30 to keep doing our work. More calls, more progress notes, more orders, taking care of any acute issues with patients, etc. This we have until, then here's when it gets complicated. On Tuesdays and Thursdays, this is on the floors only, then we have the EI rounds, which is the environment of inquiry. EI is environment of inquiry. This goes from 2:30 to 3 p.m. And so one of the floor teams prepares it for this, one of the floor teams prepares for this, and it's basically we choose a topic, an interesting topic that's relevant to one of our patient cases from the week. This is usually the resident will run it. I'll talk about it with you guys. We could split up some of the presentation to make it more interesting. so on Monday, Wednesday, Friday, you get to work from 2:30. Like, you don't get this. It's just 1:30 until like 4, okay? Around 4 p.m., this is when you should start getting sign out ready. So do your provider handoff. Drop everything else, like don't do your note. If you're still not done with notes, just do the provider handoff. This includes this will need another, so I'll tell you how to do the provider handoff in a second. Overnight things to do, things to watch out for, what happened during the day, okay? And then at 5 p.m., this probably will not happen in the beginning of the year. 5 p.m. is the earliest you could possibly sign out to either the admitting team, intern, or you just sign out to me if I'm on call. Let's see. Another thing that's not relevant to you guys is at 3:30, there's like afternoon IDRs, interdisciplinary rounds. This is like resident only. So I might go missing for like 15-20 minutes at 3:30. It's turning out longer than I thought it would be, so bear with me. Alright, the last thing I wanted to go over is how to write a sign out. Okay, this is going to be that provider handoff tab in the upper right corner of the EMR. Okay, so when you click on that tab, you're going to see there's going to be a general box up here of patient summary. Okay, there's going to be an area around here called notes. There's going to be a primary team to do box, and there's going to be a coverage to do box. This will make a lot of sense once you get used to it. And then lastly, hospital course box. Alright, so from top to bottom, patient summary. So think about what the night team, the night float interns are going to deal with. Okay, they're going to get all this printed out for them. You don't want to write too much, it'll get overwhelming, but you also don't want to leave out anything important. So patient summary, past medical history, they got diabetes, they got CHF with an EF of 40, they got a history of AFib. So this you can pretty much take from your progress note, past medical history, or the admitting note. Okay, admit. This is what they were admitted for originally. So they were admitted June 20th for shortness of breath, respiratory failure leading to aspiration pneumonia. And then you'll have your active issues. So now, this is important to know, like, okay, is this thing still active? Like, they were admitted with aspiration pneumonia. Pneumonia resolved. I like to put that there. Okay, now they're like, now they're in rapid AFib. That's controlled. Like, we controlled it during the day, but they went into rapid AFib or something like that. And then pending SAR, which is subacute rehab placement. You might see a lot of that. Okay, so this is kind of like, so you just reading this, you know what they were in for. Like, it's not a whole summary like written out, but you kind of know what they were there for. Okay, so next thing is primary to do. This is for you for the next day. Things that we need to get done the next day is get collateral from the primary doctor. We need to, like, every day we need to dose Coumadin on this patient, right? Or we need to, like, follow up physical therapy recs, stuff like that for us. Okay, this right here is for the night float team. This is very important. You either say NTD, which is nothing to do, which a lot of them will be, but some of them will be like, you need to, like, check lungs once because they're on fluids, NS at 120 cc's an hour, and this guy has CHF, so you're afraid that they might get overloaded. And then I like to put contingency stuff that's very important here. This can also put contingency stuff up here, but like, if fever greater than 100.4, perform full fever workup, which consists of blood cultures times 2, UA, and then if this is positive, they can get urine culture, and then a chest x-ray and a lactate, depending on, that's an example of what they can do, okay? So either nothing to do or a bunch of this. Notes, this is really miscellaneous stuff that they should be watching out for. Sometimes you'll be like, oh, the CT chest, showed like a whole bunch of atelectasis. I don't know. Or like, by the way, they are a Jehovah's Witness. Or like stuff just from provider to provider, demanding family members. You may want to phrase it a little better, but like, just particular, sometimes you want to be careful how you talk to certain families. By the way, like, was intubated last admission, watch out. They might get intubated again. Okay. Let me see. Oh yeah, coverage to do. This is a good place. If they're really sick, you could either write sick, at the top, all caps, or you could say like watcher. This can help delineate if they're sick or not. This last part is the more simple. It's like hospital course day to day. So if it's 621, you'll be like, okay, everything they did for the day, like we talked about before. Ordered metoprolol, dosed Coumadin, echo came back showing this. PT recommended SAR, finished antibiotics, and then every day you do the same, and this is what I mean by provider handoff. Do this at 4 p.m. so that you have it ready before 5 p.m. And then the other thing is you'll want to print out, it'll be like a list of them. Let me just write, like there's going to be a list of like, if you have like 7 patients, you'll have a cover face sheet that has all of them. And sometimes if you're on call, which I didn't talk about yet, you will label like, you did this one, canteen, I don't know. You'll label this as a call patient. Okay, that way they know that it's not on your original team, but that it's a call. Just one more thing, I just want to explain what it's like to be on call and what it's like to be on the weekend. So what's the difference between being on call and not being on call? When you're on call, you still come at 5:30, okay? Everything is the same all the way until 3:30, okay? 3:30 until 6:30 is when you can, as an intern, you're being on a call team. You'll have a different resident who's on a different team who will now be your call resident, meaning they are getting admissions, they will distribute some admissions or transfers for you to do, and they'll help out. So at 3 and 6, 3:30 and 6:30, you should on these call days try your best to get most of the important work done by 3:30, because you will be getting new admissions and new transfers. I just said that. Okay, and your resident will help you with these. I'm not going to go too much into depth about them, but the idea is you shouldn't be doing any more than 1 or at max 2 throughout the year, actually, even if it's a busy day. Once 6:30 hits, you're good to go, unless in some cases they got a call at 6:28 and they didn't get to tell you until 6:32. Then sometimes you'll still have to do an admission. Then you're staying until 8 p.m. is the time that you sign out to the night person. Okay, so make sure that if you haven't done your provider handoff before, get provider handoff done by 7 p.m. Okay? So if you have any questions, you can call me. 714-889-9342 is my cell phone. Call or text me. My pager is 917-21. I can't write. 219-1024. And I am Alan Trong. PGY, this is a G. PGY3. And today the date is 7/9/2018. Not that it really matters. So I hope that was useful. Kind of an overview. Let me know if you guys have any questions. And remember, anytime you see anything that you're worried about, just let me know. Anytime during the day, if anyone's sick, and I'll come help out. All right, see you on the floors.